Part 2 of our presentation, Integrative Cardiology for the Chelating Physician, begins with a discussion of cardio-rheumatology. We've been discussing how ACE inhibitors, beta blockers, and statins lower not just blood pressure and cholesterol, but also attenuate oxidative stress. I'd like to carry this theme forward in the cardio-rheumatology section. Cardio-rheumatology pertains to the repurposing of agents traditionally used by the rheumatologist in the treatment of joint disease, methotrexate, chondroitin sulfate, colchicine, and allopurinol, instead to attenuate the oxidative inflammatory stress that drives cardiovascular disease. Mother Nature created a finite number of oxidative stress and inflammation amplification pathways. When they're maladaptively activated in the periphery, we get joint disease. When they're maladaptively activated in the intima, we get cardiovascular disease. Big Pharma understands that inflammation is playing a key role in atherosclerosis, and Big Pharma is doing a great deal of research in agents designed to block some of these. There's a new drug, and I don't think I'm going to pronounce it very well, canakinumab, that was recently shown to improve outcome by blocking interleukin-1 beta. And it's going to be available soon, and it won't cost very much, just $10,000 a year. Well, we have colchicine, which costs a lot less than that also blocks interleukin-1 beta. I think that we have many nutraceuticals that will block the generation and expression of these inflammatory mediators, and we're going to be talking about them in this section. First of all, let's talk about methotrexate. Rheumatoid arthritis patients who take methotrexate experience a lower risk for cardiovascular disease and infarction than do rheumatoid patients who don't take methotrexate. So in rheumatoid arthritis, there's something protective about methotrexate therapy. Well, if you look at rheumatoid arthritis and other autoimmune conditions under the microscope, they're the same pathophysiology as cardiovascular disease, immune dysregulation. Thus, it's logical to ask, would methotrexate be of value in coronary disease? So we're involved in CERT, the Cardiovascular Inflammation Reduction Trial, and the plan is to get 7,000 clinically stable infarct survivors with either metabolic syndrome or type 2 diabetes. They're all going to be on standard post-MI therapy, and they're randomized to receive methotrexate once a week, variable dosing, with folic acid 6 days a week or placebo. And we're going to follow them for 5 years and look for differences in event rate, and this is a double-blind protocol. So we have a handful of patients in this study, and neither I or our research coordinator or the patient know who's getting methotrexate, who's not. The labs are being monitored elsewhere and the dose is being adjusted. So if this works, we will have a very low cost therapy to deal with the inflammation that underlies cardiovascular disease. In the meantime, we can use colchicine. Will colchicine help in cardiovascular disease? Of course, the answer is yes, or we wouldn't be talking about it. Consider gout. You've developed crystals of uric acid in the joint over the years, silently progressing, and then all of a sudden there's this inflammatory explosion with inflammation and white cells releasing inflammatory mediators. Does that sound a little bit like the conversion of chronic coronary disease into acute coronary disease? Now, we've been using colchicine to treat gout as long as I've been a physician, and it's been used in its botanical form. It's derived from the autumn crocus for centuries to treat acute gout. Now, how does colchicine work in the treatment of gout? First, we need to study the NLRP3 inflammasome. Now, this biology is going to be painful, but it's important that we understand this. Just as learning about nuclear factor kappa beta was painful, we all get that now. NLRP3 is going to be very important in medicine as we learn more about inflammasome function and how it triggers a powerful inflammatory and oxidative stress response. So NLRP3 is the nucleotide binding oligomerization domain-like receptor pairing domain containing 3 inflammasome that associates with ASC, apoptosis speck-like protein containing a caspase activation and recruitment domain, and then it converts pro-caspase to caspase. When NLRP3 is activated, it activates caspase that will convert nascent and inactive pro-interleukin-1 beta and pro-interleukin-18 to active interleukin-1 beta and active interleukin-18. So nuclear factor kappa beta translocation generates these precursor cytokines. Caspase matures them into the active cytokine. And what activates NLRP3? Frustrated phagocytosis. So NLRP3 is an intracellular danger sensing and response systems. We've got receptors on the mononuclear cell, like the toll-like receptor, the TNF-alpha receptor, the lipopolysaccharide receptor, that senses danger in the environment. So NLRP3 senses danger or dysfunction within the cytoplasm. Now, our mononuclear cells will phagocytose bacteria, bring them into a phagolysosome, and digest them. But you can't digest crystals. So if you're phagocytosing crystals of uric acid, the phagolysosome will rupture. This releases free radical mediators in a molecule called cathepsin, which causes NLRP3 to associate and convert pro-caspase to caspase. So if we have some degree of nuclear factor kappa beta translocation and low-level inflammation with pro-interleukin 1 beta and pro-interleukin 118, if we have NLRP3 activation due to frustrated phagocytosis of uric acid crystals, caspase is generated, we get interleukin 1 beta, interleukin 18, and an inflammatory response. Colchicine blocks NLRP3. If NLRP3 is not activated, these crystals become rocks. They will not cause inflammation. So interleukin 1 beta, interleukin 18 are not generated. There's no bonfire. So NLRP3 is a two-step process to get acute gout. So think about it. You've been developing deposits of crystals of uric acid in your joint for years, and it's silent, and then all of a sudden you have an acute gouty attack, and that's typically after a trigger, some inflammatory stress to increase nuclear factor kappa beta translocation. And that could be a fever, it could be an infection, a night out on the town, and then you're generating pro-interleukin 1 beta. You have frustrated phagocytosis to generate caspase 1, and then you get the oxidative storm with mature interleukin 1 beta and interleukin 18. So you have to have low-level nuclear factor kappa beta activation to make pro-interleukin 1 beta, pro-interleukin 18, frustrated phagocytosis of uric acid crystals. Now, then you're going to make a lot of interleukin 1 beta, which in turn will ligate its receptors on the mononuclear cell, and then you have high-level nuclear factor kappa beta activation, and the process moves forward. High-level nuclear factor kappa beta activation, then inflammatory mediators, cytokines, chemotactic factors, white cell recruitment, and an oxidative bonfire in the joint. Colchicine works by blocking tubulin. Tubulin is a scaffolding protein that's involved in cell kinesis and the construction of organelles. So colchicine will block tubulin assembly such that NLRP assembly is blocked. So interleukin 1 beta, interleukin 18 are not generated. White cell chemotaxis and infiltration are blunted. No oxidative bonfire. Uric acid crystals are functionally inert. So colchicine will abort and prevent the inflammatory response to uric acid crystals, because the uric acid crystals cannot cause gout if NLRP3 assembly is blocked by colchicine. Colchicine will also block generation of superoxide by inhibiting the assembly of the particles that make up NADPH. So colchicine inhibits assembly of NADPH oxidase. Low-dose colchicine inhibits superoxide production. Now, so colchicine blocks the generation of superoxide in response to a nuisance problem, uric acid, but it won't block the generation of superoxide in response to a mitogen such as PMA. So we don't think that colchicine is going to inhibit our ability to kill bacteria by generating superoxide, but it inhibits the ability to generate superoxide in response to a nuisance situation, a non-life-threatening nuisance, which would be crystals of uric acid in the periphery. So will this work in coronary disease? Well, consider, you in gout, you've been building up these crystals of uric acid over the years, and then there's an explosion of inflammation, oxidative stress to cause acute gout. Think about coronary disease. You build up cholesterol deposits in the arteries over the years, totally silent. Then you have inflammation, plaque destabilization, and an acute event. Similar pathophysiology. So let's get back to NLRP3. When it's activated, it's a response to the innate immune system to DAMPs and PAMPs. danger associated molecular patterns, pathogen activated molecular patterns. So this is not an acquired immune response to oxidize LDL. This is a innate response of the immune system to the danger posed by crystalline uric acid in the periphery. Well, this has to do with frustrated phagocytosis of crystalline uric acid, but frustrated phagocytosis of amyloid beta, asbestos, CPPD, which is involved in pseudogout, aluminum hydroxide, which is now in vaccines, silica, uric acid crystals, and crystalline cholesterol. So if we have deposits of crystalline cholesterol within the artery, there will be frustrated phagocytosis, and we will activate NLRP3 the same way that frustrated phagocytosis of uric acid crystals in the periphery will activate NLRP3. Now, will mononuclear cells phagocytose cholesterol? Mononuclear cells need cholesterol, same as every cell in the body, so they have an LDL receptor, and they can bring in LDL when they need LDL. If they don't need LDL, they'll withdraw their LDL receptor. They will not incorporate excessive free cholesterol. Now, of course, mononuclear cells can incorporate oxidized LDL via the scavenger receptor, and in the situation of intense inflammatory stress, when the mononuclear cells are in hyperdrive, they'll actually pinocytose cholesterol. But the question is, will they phagocytose crystalline cholesterol? We're not talking about incorporating an LDL molecule. We're talking about phagocytosing crystals of cholesterol. And indeed they can. If you culture mononuclear cells with crystalline cholesterol, you can see the mononuclear cells will phagocytose the crystalline cholesterol. They'll do this with crystals of oxidized LDL and with non-oxidized LDL cholesterol, and they'll bring that into the cell, and they will generate interleukin-1 beta consistent with activation of NLRP3. Now, will there be crystalline cholesterol within the intima of our patients? We were taught that crystalline cholesterol is present only within advanced lesions. And that's because when we were in medical school, we're looking at histology slides. The solvents that were used would wash out the cholesterol. So to see a chunk of cholesterol, there'd be a cleft. That's kind of a gross measuring stick. Now, with monofocal, with confocal microscopy and monoclonal antibodies, you can see that crystalline cholesterol develops in the interstitial space within the artery wall early in the course of this disease. These are LDL receptor double knockout mice. So on a high cholesterol diet, they will develop atherosclerosis. So here we have the mouse on a regular diet, and then here we put them 2 weeks, 4 weeks, 8 weeks, and 12 weeks on a high cholesterol diet. They will develop atherosclerosis. And what you'll see is this will be accompanied by the presence of crystalline cholesterol within the artery wall and a mononuclear response. So we have experimental atherosclerosis, and within this model, we see crystalline cholesterol and a mononuclear response. Now, these are the LDL receptor double knockout mice. They will develop atherosclerosis on a high lipid diet. If you also ablate NLRP3, atherosclerosis is blunted. If you ablate ASC and then interleukin-1 beta, which is downstream, atherosclerosis is blunted, suggesting but not proving that NLRP3 is necessary for the genesis of atherosclerosis. If that's the case, if we could block NLRP3, and we'll talk about doing that with colchicine, perhaps, just perhaps, colchicine would block the genesis of atherosclerosis, and we can use it as a primary prevention as opposed to a therapy that protects against adverse events, as we'll talk about in a few moments. So is this relevant to human atherosclerosis? I think it probably is, because we know that interleukin-1 beta, which is generated via caspase converting nascent pro-interleukin-1 beta to mature interleukin-1 beta, will ligate its receptor on a mononuclear cell. You get high-level nuclear factor kappa beta translocation. Inflammatory cytokines and chemotactic proteins will be elaborated. Now, NLRP3, along with maturing interleukin-1 beta and interleukin-18, makes a molecule called HMGB1, high mobility group box 1 protein that causes endothelial activation. When you think about gout, obviously there must be endothelial activation to allow white cells to traverse the endothelium to get into the interstitial space. So, and high mobility group box protein 1 generated by NLRP3 will produce endothelial activation here in gout, and that we would consider this endothelial dysfunction if this is occurring in the coronary artery. So, colchicine and coronary disease. Now, if we treat our patients with colchicine, it will concentrate in leukocytes 50-fold above that in the circulation. It blocks the NLRP3 inflammasome. The inflammasome is activated by uric acid and cholesterol crystals and generates interleukin-1 beta, interleukin 18, downstream IL-6, and HMGB1, which causes endothelial dysfunction. So let's take a look at the effect of colchicine in cytokine suppression in patients with known cardiovascular disease. We're going to take 83 consecutive subjects undergoing clinically indicated angiography. 40 have an acute coronary event, unstable angina or infarct. 90% are on statins. They're all on aspirin. 2/3 on ACE inhibitors. 3/4 on beta blockers. 33 are undergoing elective angiography to deal with chronic stable angina. They too are on protective therapies that lower the generation of superoxide. 10 of the subjects didn't have significant coronary disease. They either had false positive stress test or non-coronary chest pain, and they too were on therapeutic agents that are associated with attenuating oxidative stress. So what we're going to do, we're going to measure interleukin-1 beta, interleukin 18, which are products of NLRP3 caspase activation, and IL-6, which would be downstream from nuclear factor kappa beta translocation. We'll measure this in the ascending aorta, what's leaving the heart, the inferior vena cava, what is returning to the heart, and within the coronary sinus, which would reflect the generation of cytokines within the coronary arteries themselves. Then we're going to randomize the ACS and chronic stable angina patients to receive 6 to 24 hours prior to angiography colchicine, 1 milligram, and then 0.5 milligram 1 hour later, or no colchicine. So you have these patients with chest pain undergoing angiography. You're going to give them a single shot of colchicine and see what effect that might have on cytokine elaboration. So this is interleukin-1 beta. You can see the patients with chronic stable angina and the patients with acute coronary syndrome had higher levels of interleukin-1 beta than the controls. And you can see that there's a step up between the systemic levels and the coronary sinus levels in both the chronic stable angina and the acute coronary syndrome patients. And the step up is greater in the unstable patients because in this situation, NLRP3 has been activated, there's inflammatory and oxidative stress, and that's why they have unstable angina. You see a similar situation with interleukin-1 beta, and you see a big spike in IL-6 in the unstable patients. So here we're going to look at the gradient between the systemic level and the coronary sinus levels of interleukin-1 beta, interleukin 18, and interleukin 6. With or without colchicine. So without colchicine, the unstable patients, they're cranking out a lot of interleukin-1 beta. A single dose of colchicine dramatically attenuates at nearly the control level. Same thing with interleukin 18 and really knocks down interleukin 6. So this is another way of looking at it. This is coronary sinus interleukin-1 beta. The controls have low levels. The chronic stable angina patients untreated, 9.3, you attenuate that a little bit with colchicine. It's much higher in the unstable patients, you attenuate it a lot. I think the greater the level of elaboration of inflammatory cytokine, the greater will be the relative reduction if you block its elaboration with an agent such as colchicine. And you really knock out interleukin 6. So how will this work in our patients with chronic stable coronary disease? 200 subjects with stable coronary disease, all on aspirin, all on atorvastatin, 80 milligrams, high dose atorvastatin. Despite this therapy, 64 of the 200 had a CRP above 2. So they were divided into two groups. 20 were the observational group, no change in program. The other 44 kept up with their prior treatments and took colchicine, 0.5 milligrams twice a day. You'll repeat the CRP at 4 weeks, non-randomized open trial, and there were no significant side effects. They tolerated the therapy well. And what you see, CRP fell over time a little bit in the observation group. It fell a lot more, from 4.3 to 1.8 with colchicine. There was an 11% reduction in CRP in the observation group, a 60% reduction with colchicine. Their target was a final CRP below 2. They felt that would be an effective treatment effect. That was achieved in only 15% of the observation subjects and in 70% of those receiving colchicine. So it will lower CRP in chronic stable patients. So CRP fell in all colchicine-treated patients. The mean reduction was 2.8 points, 60%. Reduction over 50% in 2/3, and in 70% the CRP fell to below 2, which was their target. Will this reduce event rate? 493 subjects with stable coronary disease, all with abnormal angiograms. They've been stable for 6 months. The majority have undergone revascularization, and they're on standard medical therapy: statins, aspirin or clopidogrel, 2/3 on beta blockers, 2/3 on ACE inhibitors, which we know is going to lower the generation of superoxide. Will colchicine add to that protection? So you randomize them to receive colchicine, 0.5 milligrams a day or placebo. Now, the side effect of colchicine is diarrhea, which is dose-related. 22% of the subjects withdrew from colchicine therapy, 11 within the first 4 weeks due to diarrhea, 11%, an additional 11% over the following 2.5 years. And that's typical of any new drug study. You're going to get 20% of the patients drop out. You'll record event rate over the next 3 years. Minimum follow-up is 2 years. Double-blind protocol followed. What you see, the primary outcome was a composite of an acute coronary event, an MI or unstable angina, out-of-hospital cardiac arrest, or a non-embolic ischemic stroke. There was a 67% risk reduction with colchicine therapy. The event rate was 16% in the control group, 5.3% in the control group. All subcategories of patients improved. Now, this was with intention to treat. If you reanalyze the data, including only the patients who were able to stay on colchicine, the event rate reduction was 75%. So going on adding colchicine to standard drug therapy, 3 out of 4 people that were supposed to have an event did not have an event because NLRP3 activation was blunted. They could not make caspase. They didn't convert nascent inactive interleukin-1 beta and interleukin-18 to active interleukin-1 beta and interleukin-118. They did not have the oxidative inflammatory storm that would follow NLRP3 activation within the coronary arteries. Now, components of the primary outcome: acute coronary syndrome was attenuated. So acute coronary disease and acute gout share a common pathophysiology. NLRP3 activation in the joint. NLRP3 is activated due to frustrated phagocytosis of uric acid crystals. In the coronaries, the mononuclear cells of the innate immune system are phagocytosing crystals of cholesterol, activating NLRP3, and we get the inflammatory storm. Now, colchicine does not blunt stent-related ACS. That is a different physiology. It's not preventing restenosis per se or events related to the stents, but non-stent related ACS, myocardial infarction, unstable angina were dramatically blunted. So colchicine physiologic effects, how does it fit into our rules? Well, oxidative stress is reduced, inflammatory stress reduced, endothelial function improves. That was shown in an animal model. I won't show you that study, but we know that NLRP3 activation leads to endothelial dysfunction via HMGB1. Colchicine blocks that. We would anticipate that colchicine would improve endothelial function, and that's been shown in an animal model. We would assume the same holds in humans. Clinical use of colchicine. Accepted benefits in the treatment and prevention of gout. Familial Mediterranean fever and Behçet's disease are characterized, my understanding is that they have to do with genomic upregulation of NLRP3. So they're constantly experiencing inflammation. Colchicine attenuates that. We've been using colchicine to deal with pericarditis and post-pericardiotomy syndrome. Perhaps particulate matter in the pericardium is leading to NLRP3 activation to cause pericarditis and post-pericarditis syndrome. That's a hypothesis on my part. I don't think that's been looked at. Cardiovascular demonstrated benefit: acute reduction in coronary sinus generation of interleukin-1 beta, interleukin-18, and interleukin-6. CRP reduction in chronic coronary disease, event rate reduction in stable coronary disease. Restenosis post bare metal stents in diabetics is blunted. Neointimal proliferation following bare metal stent placement is blunted. It didn't protect against adverse events, but the study only went on for 6 months, but it did blunt neointimal proliferation and recurrent atrial fib post-ablation. Colchicine works in relation to its ability to lower the generation of inflammatory cytokines. So recurrent fib post-ablation, inflammation is playing a role. Colchicine may be helpful there. Experimental positive effects, the animal model, the LDL receptor double knockout mice, blocking NLRP3 blocked initiation and progression of atherosclerosis. So our hypothesis is that if we could block NLRP3 with colchicine or any other agent, we might block the generation of atherosclerosis. It has not been shown to be beneficial in blunting restenosis post-balloon angioplasty. In heart failure patients, inflammation falls, but clinical outcome does not improve. Colchicine clinical uses. It comes in 0.6 milligram doses, and I typically have patients take it once a day. Now, as you all know, colchicine used to cost pennies a day, and then the FDA commissioned a drug company to do a randomized double-blind trial to prove that it works. The FDA was troubled that no one had ever proven that colchicine works. Now, we all know that colchicine works, but they wanted to have this study, and by golly, it did work, as you would expect. But in the process, they awarded a patent to the drug company. So now colchicine, which used to cost next to nothing, is now rather expensive. There are 2 companies that make colchicine. One comes in tablet form, one comes in capsule form. So I write a script for colchicine 0.6 milligrams a day. Either of the forms are okay. And the reason I do that is insurance company A may want one, insurance company B may want another. I don't want them just to reject it because I picked the wrong brand name. So I put both on the script. Now, the insurance company may balk because they don't understand why we're using colchicine. They think it's only for gout. And if they balk, I will send them that article showing the 75% event rate reduction, and I write them a letter saying, gee, I think that lowering risk of a heart attack by 75% is a good idea. Why are you fighting me? And then they always give in. So you can send that article, and then the insurance companies will go along with us. Side effects. 10% get diarrhea, 5% get nausea, decrease the dose. The colchicine will concentrate in leukocytes 50-fold over circulation. The half-life is days to weeks. So you can have them take it every 2 to 3 days, and you're still going to get an effect. So I find a way to make it tolerable for the patient. Now, in some of the articles, they say, gee, there's this interaction with colchicine and statins to cause myalgia. That does not appear to be the case, because in all the studies that I've read, and there's been about a dozen, colchicine was added to standard drug therapy, including statins, and there was no increased risk of myalgia when you add colchicine to statins. It is metabolized via CYP3A4 and P-glycoprotein. So therefore, we're going to use lower doses and caution if the patient's also receiving a strong inhibitor of those pathways. And the drugs of interest here, cyclosporin, clarithromycin, ketoconazole, ritonavir, and pertaining to cardiovascular medicine, long-acting verapamil and diltiazem would perhaps plug up these enzyme systems and raise the clinical effective dose of the colchicine. So we would be cautious here. No issue with the Zithromax, azithromycin, or grapefruit juice. Oxidant versus antioxidant balance. That is why our patients are seeing us. They're making more free radicals than they can neutralize. And indeed, if we look at the level of SOD3, extracellular vascular wall superoxide dismutase, it is lower in patients with coronary disease than in healthy controls. NADPH oxidase, which generates superoxide, is greater. Xanthine oxidase, which also generates superoxide, is greater. This all makes sense. Our antioxidant defenses are attenuated. The enzyme systems that generate superoxide are upregulated. That's why the patient has cardiovascular disease. So as part of our integrative approach to oxidative stress, Let's now discuss xanthine oxidase in the treatment of cardiovascular disease. I'll start with the most important study, allopurinol in chronic stable angina. 65 patients with stable angina, reproducibly positive stress test, abnormal angiogram, their GFR is above 45, normal is 100, the cutoff from normal to abnormal is 60, so their kidney function was intact. Elevated uric acid was not a criterion. We're not using allopurinol to treat gout. We're not using allopurinol to treat uric acid. We're using allopurinol to lower oxidative stress. Baseline stress EKG and angina frequency assessment randomized these subjects to receive over 6 weeks placebo or allopurinol 600 milligrams a day. 100 milligrams a day for week 1, 300 milligrams a day week 2, then 300 milligrams twice a day. Prior meds continue without a change. Repeat the stress EKG. Then you wash them out, you cross them over, and obtain a third stress EKG 6 weeks later. So this was a double-blind, placebo-controlled crossover trial. No significant side effects. No change in the labs except uric acid fell from 6 to 2.3. And it would seem, based on all the papers I've read, if we're going to be treating a patient with coronary disease with allopurinol, a uric acid around 2 would be a good treatment goal. We're not lowering uric acid per se, we're lowering oxidative stress, but uric acid is a surrogate for superoxide generation via xanthine oxidase. AST fell insignificantly, BNP fell slightly from 84 to 66. I wonder why that happened. So what did they find? Time to chest pain increased by 30 seconds. That was not statistically significant with placebo therapy. It increased a statistically significant 60 seconds with allopurinol. Time to ST depression, supply-demand mismatch for oxygen such that you can't make ATP, increased insignificantly with placebo therapy. It increased 60 seconds with allopurinol therapy. Total exercise time increased by 90 seconds. The median treadmill time increased by 43 seconds, which is 19% increase in treadmill time, similar to that achieved with therapy with conventional agents such as amlodipine, nitrates, atenolol, or ranolazine. So allopurinol worked in chronic stable angina. It improved treadmill time, time to pain, and time to ST segment depression. Angina frequency decreased by 50%. Nitroglycerin requirement fell significantly. Those that were using nitro at least once a week, nitroglycerin requirement fell from 2 tabs to a half a tab. So treadmill time improves, less angina, less requirement for nitroglycerin. So allopurinol lowers anginal burden, improves treadmill time. How does this work? I mean, is it improving the supply of oxygen? Or is it decreasing the demand of oxygen? How is it working? Will allopurinol also improve outcome? Now, if we treat our patients with atenolol, we will attenuate angina and improve outcome. If we treat our patients with ranolazine or amlodipine, we will relieve angina but not improve outcome. Long-acting nitrates as a monotherapy will actually worsen outcome because when you take a nitrate, you use up glutathione, converting the nitrate into nitric oxide, you'll get endothelial dysfunction, nitrate intolerance, and oxidative stress, which of course we can attenuate if you co-administer antioxidants. So how does allopurinol going to fit into here? It's obviously relieving angina. Will it also improve outcome? Well, allopurinol blocks xanthine oxidoreductase. And in a 2-step process, xanthine oxidoreductase will convert hypoxanthine, which is a breakdown product of adenosine, which is generated when we have energy failure, when we cannot recycle ADP to ADP. We break it down to adenosine, hypoxanthine. We go from hypoxanthine to xanthine, and then xanthine to uric acid, which is trioxypurine. In a reductive environment, xanthine oxidoreductase uses NAD as its cofactor and creates NADH, a benign molecule. In an oxidative and inflammatory environment, xanthine oxidoreductase uses oxygen as its cofactor, generating superoxide and hydrogen peroxide. So in an oxidative environment, xanthine oxidoreductase contributes to free radical stress. Now, the enzyme is transcribed as xanthine dehydrogenase. It will then be converted to xanthine oxidase in the presence of inflammation and oxidative stress. So in the presence of oxidative stress, there is oxidation of sulfhydryl groups in the xanthine dehydrogenase molecule, and it begins to function as the oxidase. With ongoing oxidative stress, there's proteolytic cleavage of some of the amino acids, and then it's permanently rendered the oxidase. So transcription of xanthine dehydrogenase and conversion to the superoxide and hydrogen peroxide generating xanthine oxidase is promoted by oxidative stress, hypoxia, lipopolysaccharide, Th1 cytokines, particularly interferon gamma, and cortisol. All the conditions that we would see in the patient with coronary disease. They have hypoxia, they don't have enough oxygen, they have oxidative stress, there's inflammation. So within the coronaries and within the myocardium in the patient with heart failure, we have upregulation of xanthine dehydrogenase, and it's converted to its oxidase form, so it's generating copious amounts of superoxide and hydrogen peroxide. So if we're cranking out all this superoxide and our defenses are insufficient, we cannot neutralize superoxide to hydrogen peroxide and then convert it to water and oxygen. It can be converted to hydroxyl, particularly if there's metals on board. It can go to peroxynitrite, which will degrade nitric oxide and cause endothelial dysfunction. The peroxide can go on to hypochlorous acid, which is great when you want to kill microbes, but it's not great when all these free radicals are damaging cells within the enema. So allopurinol effect on Roberts's rules, we're going to block oxidative stress. A great deal of oxidative stress in the patient with acute and chronic coronary disease is being generated by upregulation of xanthine oxidase. If we block that, we lower oxidative stress. All the other phenomena will follow. Remember, aberrancy at any one loci will adversely affect the other loci. Correction at one loci, lowering oxidative stress, will favorably affect the other loci and promote health. So how does it work? How does allopurinol work in chronic stable angina? Well, does it decrease heart rate and blood pressure like a beta blocker or an ACE inhibitor? No, it does not. Here we're going to look at heart rate at rest, stage 1, and maximal exercise. Baseline, placebo, allopurinol. Exercise heart rate increases with allopurinol. Systolic blood pressure increases, the double product increases. So it's not decreasing demand by lowering heart rate and blood pressure like a calcium blocker or a beta blocker. It must be doing something else. Does it spare oxygen? Yes, it does. So xanthine oxidase uses 2 oxygens to convert adenosine, a breakdown product of ATP that we cannot recycle, to uric acid and superoxide. So yes, it will spare oxygen. So if you have angina, it's because you don't have enough oxygen in the myocardium supplied by the narrowed artery. If the heart stops wasting oxygen doing something maladaptive like making superoxide, you have more oxygen available to recycle ADP to ATP. So yes, it spares oxygen. Will it spare nitric oxide? Well, yes, it will, because we know that superoxide will react with nitric oxide to form peroxynitrate, which will uncouple nitric oxide synthase, creating a generator of further superoxide. So it will improve endothelial function. If we improve endothelial function, we will have less angina. So it works by sparing oxygen, sparing nitric oxide. This leads to coronary vasodilatation, peripheral vasodilatation, and with heart failure, it promotes mechanical energetic coupling. Within the heart, the ratio of nitric oxide to superoxide determines the efficiency of contractility. When we have oxidative stress, too much superoxide, the heart becomes inefficient. It does less work with each molecule of oxygen it uses. So this is blocking superoxide generation is important not just in coronary disease, but in heart failure. And allopurinol will block the generation of superoxide, sparing oxygen, sparing nitric oxide. The fructose uric acid oxidative stress connection. Hepatic, we are not supposed to be taking in high quantities of fructose. Primitive man got fructose in sucrose when we would eat fruits and berries, but we're not supposed to be taking in high quantities of fructose from table sugar or from high fructose corn syrup, which is the sweetener used in commercial beverages. This is a total disaster. Now, fructose is distinct from glucose only in its initial metabolism. Fructokinase, otherwise known as ketohexokinase, converts fructose to fructose 1-phosphate. So it's going to take a phosphate from ATP to phosphorylate fructose. This is unregulated. There's no negative feedback. So the more fructose that you take in, the more ATP will be burned. So this will lead to energy failure in the liver because we're spending all our ATP phosphorylating fructose. So high sucrose, high fructose corn syrup intake leads to an ATP to AMP drain. And when we have AMP, we activate AMP deaminase, which initiates the conversion of AMP to uric acid. AMP deaminase antagonizes AMP-sensitive protein kinase. Now, AMP-sensitive protein kinase sends a signal, don't build, burn. Burn sugar, burn fat, lose weight, lower oxidative stress. We want to activate AMPK, and we do that with caloric restriction, exercise, agents such as berberine. AMPD, just the opposite, it sends a signal, don't burn, start storing. So you get this biochemical antagonism to AMPK. Then uric acid itself, which is the downstream product of hepatic metabolism of fructose, leads to upregulation of fructokinase expression. So the more fructose you've taken in, the more energy failure in your liver, the greater the generation of uric acid in the liver, the more sensitive you will be to further adverse effects if you take in more fructose. Uric acid leads to mitochondrial oxidative stress. Uric acid in the circulation is an antioxidant. But when uric acid enters the cell, it leads to oxidative stress. It's sort of a paradoxical phenomenon. We used to think of uric acid as a good guy because in the circulation it's an antioxidant. It'll scarf up free radicals. But once it enters the cells, it leads to mitochondrial oxidative stress. With mitochondrial oxidative stress, citrate will be diverted away from the Krebs cycle and towards triglyceride synthesis, and we get fatty liver. So this is the mechanism through which high fructose corn syrup and high table sugar leads to fatty liver. Now, when Mayor Bloomberg proposed limiting the sizes of drinks in New York City, I thought, we kind of made fun of him. We called him Nanny Bloomberg, but he was absolutely right because we're destroying ourselves by taking in high fructose corn syrup. One of the reasons that teenagers are overweight today is they're drinking soda pop with high fructose corn syrup. Now, when we were younger, we drank soda pop too, but it had sucrose in it, not this high fructose corn syrup. It's not the calories, it's the chemistry. High fructose corn syrup is a metabolic disaster for us. Now, so no more high fructose corn syrup for us. Allopurinol and progression of chronic kidney disease and cardiovascular risk. One of my themes is that anything that improves the biochemistry of the heart, that improves the biochemistry of the artery, is going to improve the biochemistry of any other organ system. The kidney, in a sense, is one huge endothelial surface. Will allopurinol be of value here? 113 subjects with a GFR below 60, normal is 100, 60 is the cutoff, is abnormal. Baseline measures, randomized to receive over 24 months, placebo or allopurinol just 100 milligrams a day. Relatively low dose. Periodic evaluation of their renal and cardiovascular status. All prior treatments continued. Double-blind protocol followed. Uric acid levels did not change much with placebo therapy over 24 months. As you would expect, they fell promptly and stayed low with allopurinol. They dropped from 7.8 to 6.0. Now, in the other studies, we used 600 milligrams. You're going to get down to 2. They used only 100 milligrams, so they got down to 6. GFR dropped with placebo therapy. As you'd expect, if you have chronic kidney disease, the natural history is to slowly worsen. GFR improved with allopurinol. Protein spillage, albuminuria, increased over time with placebo. It was attenuated with allopurinol. C-reactive protein fell, fibrinogen fell with allopurinol. You're lowering oxidative stress, then you're going to lower inflammatory stress, and vice versa. So allopurinol's effect on Roberts's rules, we're lowering oxidative stress, inflammation is going to get better, endothelial function is going to get better. All these phenomena will improve if we lower oxidative stress, which we can do with allopurinol. So what was what effect did it have on outcome? 2 of the allopurinol subjects withdrew due to GI intolerance. A renal event, the initiation of dialysis, doubling of serum creatinine, or a greater than 50% drop in GFR occurred in 2 of the 57 subjects assigned to allopurinol, 100 milligrams a day, versus 6 of 56 controls. So the relative risk of a renal event was 47%. So your risk of this renal event falls by a half. Cardiovascular event, 7 of the 57 receiving allopurinol versus 15 of the 56 in controls, relative risk was 71%. 2 progressed to dialysis, 1 in each group, 2 deaths in the control group. Hospitalization risk was decreased with allopurinol. They didn't give numbers, but here is cardiovascular event-free survival was dramatically improved with the addition of allopurinol 100 milligrams a day to standard therapy in these patients with chronic kidney disease. So then they offered to the patients, they could continue in the study over an additional 5 years. So 107 of the initial 113 subjects with additional 5-year follow-up. 1 of the 57 in the allopurinol group was lost to follow-up. 3 of the 56 controls were lost to follow-up, 2 died. 10 of the original controls decided to switch over to allopurinol, which made a lot of sense. 12 of the original allopurinol subjects decided to stop treatment. That was their choice or the physician choice, which was kind of a dumb idea in retrospect. So after 5 years, new renal event in 7 of 56 allopurinol subjects versus 18 of 51 controls, new cardiovascular event about the same, 9 of 56 and 8 of 51. But if you look at over 7 years, a renal event in 9 of 57 allopurinol subjects versus 24 of 56 controls, relative risk is just 68%. Cardiovascular event in 16 versus 23, risk reduction roughly 50%. This is a great idea. Allopurinol, 100 milligrams a day, pretty well tolerated, protects against the anticipated decline in kidney function, protects against the anticipated increase in proteinuria, protects you from an adverse kidney event and an adverse cardiovascular event. So this is cumulative risk of a renal event is much greater with the controls versus allopurinol over a 7-year follow-up period. Xanthine oxidase as an ischemic marker. We talked about how xanthine oxoreductase transcription and conversion of xanthine oxidase will be upregulated with inflammation, oxidative stress, and hypoxemia. We could actually use xanthine oxidase as a marker of coronary ischemia. Here we're going to look at non-smokers in the 40 to 65-year-old range, 100 with acute MI, 125 healthy controls. You can see that xanthine oxidase is dramatically upregulated. So xanthine oxidase is found on the endothelium. It's bound to the endothelium, and it will be upregulated in a coronary artery that is experiencing ischemia and oxidative stress. So here they were proposing using xanthine oxidase like we use troponin or CPK as a marker of acute injury because it's going to be upregulated. And this correlates with malondialdehyde, which is a marker of lipid oxidation or LDL oxidation. We have oxidative stress and hypoxemia leading to upregulation of xanthine oxidase expression. Xanthine oxidase is going to be cranking out superoxide to create malondialdehyde. So xanthine oxidase is upregulated in coronary ischemia. Same thing in heart failure. 65 subjects with heart failure, mean New York Heart Association functional class 2.4. We have 15 healthy controls. Xanthine oxidase activity is upregulated. In diabetes, obesity, metabolic syndrome, the liver is the key generator of uric acid. In heart failure, it's the heart because xanthine oxidase activity will be upregulated in the failing myocardium, and you're going to generate a great deal of superoxide. And that's going to knock out nitric oxide, and that's going to compromise contractility. Indications for allopurinol, clinical conditions associated with oxidative stress. We're treating oxidative stress, not gout, not high uric acid. Atherosclerosis, renal dysfunction, here use 100 milligrams a day. Heart failure, particularly with low ejection fraction and high uric acid. The studies of allopurinol and heart failure were done in Europe, where they used oxypurinol, which is a metabolite of allopurinol, and they used a dose that would be equivalent to only 100 milligrams of allopurinol, and they had mixed results. But the worse your ejection fraction, the higher your baseline uric acid, the greater was the treatment result. If they repeated the studies with 600 of allopurinol, they probably would have gotten a better result. Type 2 diabetes and metabolic syndrome, hypertension, cardiovascular surgery, and gout. On my website, heartfixer.com, there's a 90-minute presentation on colchicine. There's a 90-minute presentation on allopurinol where I present all these studies in greater detail. Safety concerns. What are the downsides? 1 in 500 of our patients is going to experience an idiosyncratic hypersensitivity reaction. You start with an itchy rash, and you get eosinophilia, fibromyalgia, and then you have to stop immediately, and the patient will get better. If the patient sticks with the allopurinol despite the rash, it can progress into a life-threatening skin sloughing situation. When I was an intern, one of my first patients I saw was put on allopurinol and developed this Stevens-Johnson reaction. And since then, I was afraid to ever use allopurinol again. Now, of course, I'm using allopurinol, and I understand this potential side effect and how we can deal with it and prevent it. So this is going to occur in a minority of patients, but if they have this reaction, they must stop the allopurinol immediately, or they're going to get sick. If they have a mild rash, they can cut back on the dose. This is an allergic phenomenon that is dose triggered, so it's not really a true allergy. Patients may tolerate 100 milligrams, they go to 300, they get a rash. If the rash is bad, they stop allopurinol, they never start it again. If it's just sort of low level and low grade, I have them back off a couple hundred milligrams and then watch them closely. The risk factors for this idiosyncratic reaction would be a dose. This is dose related. So a dose above 300. If you have renal dysfunction, the allopurinol is not toxic to the kidney, but it's excreted via the kidney. So if you have renal dysfunction, any given dose of allopurinol will hang around longer. Female gender, there's a genomic variation called HLA-B star 58.01 that compromises your ability to break down allopurinol. And if you are heterozygous or homozygous for this allele, your risk is greater. It's not. I don't know that it's available in our labs. I've not looked at this yet. This is actually not a reaction to allopurinol, but a reaction to oxypurinol. When you take allopurinol, it's converted to oxypurinol. If you have it, you stop, you're going to get better. If people stick with it because they don't understand the cause-and-effect relationship, they can get very sick. Steroid therapy and support, this can be a life-threatening reaction. It's infrequent, but it can occur, so we must be aware of it. So dosing and management. Baseline assessment, look at clinical status, look at creatinine, because I know that kidney function is going to improve or at least stabilize with allopurinol, but the greater your creatinine, the lower will be my initial dose. I'm going to look at uric acid. Not that my goal is to lower uric acid, but it's sort of a surrogate of xanthine oxidase pathological upregulation. If you measure uric acid in your patients, you have a new patient who's 50 pounds overweight and they're diabetes, they lose weight, they do what they're supposed to do, their sugar control gets better, you'll see their uric acids will drop from 8 to 5 simply because you're dealing with diabetes, you're dealing with fatty liver, you're dealing with energy failure in the liver, and then the liver stops making uric acid. So uric acid is a surrogate of oxidative stress via the xanthine oxidase pathway, either in the liver or in the heart. So what I'm doing, 100 milligrams a day for 2 to 4 weeks. Then I go to 200 milligrams a day for 2 to 4 weeks, and then 300 milligrams per day. Slower updosing if renal dysfunction is present. I stop or decrease the dose if there's an adverse event. So I made up a handout sheet, and I've got little check boxes that I can use with different dosing schedules. And we're not in a hurry. And I think if we start people on 600 milligrams a day, we're going to get a lot more adverse reactions than if we start with 100 milligrams a day and slowly work our way up. At 3 months, I reevaluate. I could advance to 200 twice a day, later 300 twice a day. You can actually go up to 900 milligrams a day. Stop or decrease the dose if any adverse reaction. Avoid sucrose and high fructose corn syrup. Balance risk versus potential benefits, which are extensive. Periodic monitor clinical status, uric acid, and oxidative stress markers. I like to look at lipid peroxides and glutathione, 8-hydroxydeoxyguanosine. Those are my targets of intervention. But as a surrogate, I can use uric acid, which is easy and cheap to measure. I'm going to go for a uric acid of 2 to 4. And we have to remember, we're not treating uric acid or gout, we're treating oxidative stress. And this is working very, very well. If I put this in, if I take my patient with chronic kidney disease, I see their creatinine will drop just a smidge. In patients with chronic stable angina, angina frequency decreases. So this has been a very effective therapy. I've had a couple people develop a rash and stop. I've not hurt anybody. I've not caused a serious adverse reaction with allopurinol. Our final section covers chondroitin sulfate in the treatment of atherosclerosis. Then I will summarize and move on to the bonus coverage material. We've been discussing atherosclerosis as a maladaptive response of the innate and acquired immune systems to danger as perceived by the presence of crystalline cholesterol in the artery wall or infection with the intima with oxidized lipids. We talked all the cells of the innate immune system have threat receptors when they're ligated by lipopolysaccharide, free fatty acids, angiotensin II, etc. This will set in motion a chain reaction of serine kinases that will activate ICBA kinase that degrades ICBA, the inhibitor of nuclear factor kappa beta, allowing nuclear factor kappa beta to translocate to the nucleus, generating inflammatory cytokines and chemokines to generate the oxidative storm. And all of our immune cells bear these receptors and are capable of activating the nuclear factor kappa beta pathway, as are our somatic cells. So our somatic cells will respond to inflammation with nuclear factor kappa beta translocation. This includes cells of the joint, such as synovial cells and chondrocytes. In addition, these cells bear receptors for materials that are generated in response to joint trauma. So if there's joint trauma, there will be generation of extracellular matrix fragments, fibronectin. They will also activate these serine kinases, lead to nuclear factor kappa beta translocation. And of course, this is adaptive. If primitive man experienced some joint microtrauma after running down his dinner and he's activating nuclear factor kappa beta, one of the products is PGA2 to cause pain. And that will tell primitive man, hey, don't go out and run 20 miles the next day, stay inside and heal up. Matrix metalloproteinases are elaborated, and that will degrade the fibronectin and extracellular matrix fragments to allow tissue recovery. And that's how the situation's supposed to work. The problem occurs with modern man with repetitive joint injury due to our work using power tools that produce vibration, poor shoes, whatever. We're constantly traumatizing our joint. We have chronic malactivation of nuclear factor kappa beta. We're generating all these inflammatory cytokines and reactive oxidative species in the joint, so we damage the joint. We damage the synovial cells, we damage the chondrocytes, we chew away at our cartilage, we chew away at the subchondral bone, and then we have atherosclerosis. Chondroitin sulfate is helpful here. Now, I've always thought of chondroitin sulfate as a material that will promote hydration of the joint tissues. The proteoglycan that attracts water and hydrates the joint tissues is composed primarily of chondroitin sulfate, and it does hydrate the joint. But of greater importance and pertinent to our discussion of the use of chondroitin sulfate in autoimmune disease and atherosclerosis, chondroitin sulfate will blunt nuclear factor kappa beta translocation. First of all, in the joint, chondroitin will block microparticle binding to the corresponding receptors. It has an antioxidant effect, and we know that peroxide all by itself will shoot nuclear factor kappa beta to the nucleus, so chondroitin's antioxidant effect is of value here. Two of the three major serine kinases that will activate ICBA kinase and degrade ICBA to allow nuclear factor kappa beta to translocate, extracellular radikinase 1,2 and P38 mitogen activated protein kinase are blunted by chondroitin sulfate. So chondroitin sulfate blunts nuclear factor kappa beta translocation in the joint, thus blunts the inflammation that characterizes I said atherosclerosis, but osteoarthritis. And of course, we're going to talk about how it works in atherosclerosis. But when you think about all the disease states that involve inappropriate inflammation and oxidative stress, in common, they all have maladaptive and inappropriate nuclear factor kappa beta translocation. We could hypothesize that chondroitin sulfate would be of value in many diseases. On my website, there's a 60-minute presentation on chondroitin. I will present studies showing how it regresses psoriasis and maintains remission in inflammatory bowel disease. We all understand that it's of value in osteoarthritis, and I think it's being looked at in these other neurodegenerative conditions that are also associated with nuclear factor kappa beta translocation. Of course, we'll cover its use now in. So we consider atherosclerosis as a maladaptive response to the immune system, what it perceives as infection with oxidized lipids within the vascular wall. Before the LDL particles can become oxidized, they first must enter the artery wall and then become trapped. If LDL enters the artery wall, and there are no open LDL receptors because all the cells in the intima have enough cholesterol, they can swim right out. But if they're trapped, then they're subject to oxidative stress. And they trap onto chondroitin sulfate in proteoglycan. Lipid trapping can take two pathways. First, phospholipases can oxidize the phospholipids in the outer coating of the LDL, causing them to stick together and they clump, and then they can bind to sticky chondroitin sulfate, particularly in the presence of oxidative stress. They will trap onto the proteoglycan, they can't swim out, and then free radicals generated by all the cells in the intima can oxidize the LDL. Then it is regarded by a macrophage as a bacteria. It is phagocytosed, and that initiates and drives atherosclerosis. All the cells of the intima will generate chondroitin sulfate proteoglycan, and it will bind to and tether LDL. And this makes sense because LDL is food for the cells of the intima. They want to keep their food supply at hand. It becomes pathological when lipids are trapped and then they're oxidized and phagocytosed by macrophages. Indeed, macrophages will generate much of the chondroitin sulfate, and it's involved in binding of oxidized LDL to the membrane of the macrophage, followed by incorporation. If we look at the content of chondroitin sulfate proteoglycan within the intima, it rises with progressive atherosclerosis, and it's involved in the incorporation of LDL and oxidized LDL into the macrophage. So what is proteoglycan? Proteoglycan, there's a backbone of hyaluronic acid to which is attached core proteins, to which is attached monotonous repetitive disaccharide chains, such as with chondroitin sulfate. There's many other forms of proteoglycan. Pertinent to our discussion is chondroitin sulfate, which is key in lipid trapping within the intima. So we feel that if we supplement with chondroitin sulfate, we can block lipid trapping, and you can show this in vitro. If you knock out chondroitin sulfate, binding of LDL and oxidized LDL to the macrophage is blunted. So we think theoretically, if we supplement with chondroitin sulfate, we'll block LDL trapping in the vascular wall and incorporation into the macrophage. Let's see if this will work. The squirrel monkey is a good animal model of human atherosclerosis. Unlike other higher mammals, except for man, squirrel monkeys may develop atherosclerosis in their natural setting. So they're a good experimental model. So we're going to take these squirrel monkeys, assign them to one of four treatment groups: standard diet of Purina monkey chow, 78% chow diet plus an atherosclerotic component, pro-atherosclerotic component, 2% cholesterol, 20% butterfat, the bad diet and sub-Q saline, the atherogenic diet and sub-Q chondroitin sulfate A, 10 milligrams a day. You examine the aorta at 9 months and rate plaque deposition on a 0 to 4 scale. No visible lesions is 0. Marked atherosclerotic plaque is 4. On the chow diet, they do have low-level atherosclerosis because this is an animal model that is susceptible to natural atherosclerosis. On the atherogenic diet, you have much greater plaque representation. With the bad diet and chondroitin sulfate, not only do you have less plaque than on the chow diet, you're dramatically decreasing atherogenesis on the bad diet. So in this animal model, chondroitin sulfate A blunted atherosclerosis in relation to an atherogenic diet of high cholesterol and high butterfat intake. So this is the aorta of a young monkey without atherosclerosis. This is a cholesterol-fed monkey. This is a cholesterol-fed monkey given heparin, which is very similar to chondroitin sulfate. This is the aorta of a cholesterol-fed monkey given chondroitin sulfate. You can see that there's just no atherosclerosis. Chondroitin sulfate prevented diet-induced atherosclerosis in this animal model. Here we're going to take human adult coronary intima cells and tissue culture, and you're going to load them with serum lipids and lipoproteins and stain for fat with Sudan 4, and then you're going to incubate them with chondroitin sulfate A for 3 days, and you wash it right out. The theory being that chondroitin sulfate mediates binding of lipids to proteoglycan. If we interfere with that by throwing in an exogenous chondroitin sulfate, the lipids are no longer bound to proteoglycan and they're going to wash out of the tissue. When this concept came out, I missed it, but I don't feel too bad because I was in 8th grade. Lester Morrison was probably the nation's first integrative cardiologist. He did a lot of work with unsaturated phosphatidylcholine, and he introduced us to the benefits of chondroitin sulfate in cardiovascular disease. He wrote 2 books, Coronary Heart Disease and the Mucopolysaccharides, which is his term for glycosaminoglycans derived from chondroitin sulfate. He wrote another book, Dr. Morrison's Heart Saver Program. And he published a number of papers documenting the benefits of chondroitin sulfate in cardiovascular disease. And this is his most important paper, published again when I was in 8th grade. 120 patients with stable coronary disease, abnormal EKG, 28 prior infarction, 79 had angina, mean age 66, a typical patient population. Baseline assessment divided into 2 treatment groups, and it was an alternate day group assignment, and he matched them for age and clinical condition. So this was not a $30 million multi-center randomized double-blind study. This is a group of doctors in their practice doing research with the best methods available to them at the time. And again, this was 40, 50 years ago. All prior therapies were continued, state-of-the-art, 1969, quite different from what we use today. And they made their own chondroitin sulfate A. They obtained cattle trachea from the slaughterhouse, ground it up, purified it, and made chondroitin sulfate A. 60 of the subjects received chondroitin sulfate, 60 were the control group, and the dose was 1.5 to 10 grams per day. He started at 10 grams and then cut back to 1.5 grams a day at variable time intervals, usually within 3 to 6 months. Periodic reassessment, mean follow-up 2 years. Event rate, there was only 1 event in the chondroitin group. There were 16 events in the control group. Fatal MI, non-fatal MI, unstable angina. There was just 1 event, 1 fatal MI in the chondroitin group at 2 years. He extended this for 2.5 years. 3 coronary events in the 60 patients assigned to chondroitin, 21 events in those in the control group. Then they looked at over 4 years. Event rate was 60% with controls, 10% with chondroitin. The patients in the chondroitin group who had events, some of them had been off treatment. They were traveling or they ran out of chondroitin, and that's when they had the event. But otherwise, a remarkable protection from cardiovascular events with simple supplementation with chondroitin sulfate. And at this point in 1969, he did not have the methodologies that we have today to understand the biochemical effects of a given substance. He hypothesized that the benefit of chondroitin had to do with lipid clearing, anti-inflammation, anti-thrombotic effect, stimulate cellular metabolism, increase fatty acid turnover, anti-allergy, and stimulation of collateral circulation. And we know that it does have anti-inflammatory and lipid clearing events. But regardless of the mechanism, the result was fantastic, dramatic reduction in event rate over 4 years. So there's an hour presentation on the heartfixer.com website where I present all the studies that have been published that are pertinent to our discussion, but chondroitin sulfate is of documented value in atherosclerotic vascular disease. Similar studies were carried out in Japan to show the same thing. It's effective in psoriasis, it's effective in osteoarthritis. Chondroitin is likely of value in inflammatory bowel disease. It's been shown to help maintain remission. It was dramatically beneficial in maintaining remission in patients with Crohn's disease and ulcerative colitis. It's probably going to help in gout by blocking the initial signal of nuclear factor kappa beta translocation. It's probably going to help in all other Th1 and Th17 autoimmune conditions. What is the mechanism of benefit? It blunts nuclear factor kappa beta translocation. Pertinent to atherosclerosis, LDL and oxidized LDL binding to intimal and macrophage proteoglycan is blunted. It might have an anticoagulant effect. It might have a lipid-lowering effect based upon some Japanese studies. Clinical risk is nil. Now, glucosamine sulfate may compromise insulin sensitivity. Chondroitin does not. It is not metabolism through P450, so it's not going to interact with any of our prescription agents. The key questions: what is the best source? Bovine, porcine, or marine? What's the best dose? I would think 750 to 1500 milligrams twice a day. Which vendor? Now, in Europe, chondroitin sulfate is a drug. It's a standardized material, you know exactly what you're getting. Here it's over the counter, so we don't know exactly what we're getting. So I'm sort of reaching out to our nutraceutical suppliers, and I'm asking them to create a chondroitin sulfate of defined potency. Maybe we could do some in-house research on it, but I think we need a good, strong chondroitin sulfate that we can depend upon, because if we extrapolate Morrison's results to our patients, it's of great value. Many of our patients have untreatable hyperlipidemia. They can't take a statin, they can't take anything. So I'm thinking if you have hyperlipidemia, but we treat you with chondroitin sulfate, if we keep the lipids from getting trapped in the artery wall, we're really going to be neutralizing the atherogenic effect of the hyperlipidemia. So it seems like a great idea for all of our patients, particularly those with hyperlipidemia who we have trouble treating. So the question is, where are we going to get this stuff? Well, with an important question like that, we turn to RH Polling and the RH Polling Metabolic Institute, and we tasked them with finding an American source of chondroitin sulfate. So the brain trust at the Polling Institute, which is me and Polling, we were asked to come up with an American source of chondroitin sulfate. At the same time, we were tasked with dealing with the big-headed carp threat. So these big-headed carp are swimming up the Mississippi, and it's being a big problem. They're jumping out of boats and hitting kids in the head, and they're causing people to behave in a strange fashion. So we have to find a way of getting rid of them to avoid them getting into the Great Lakes. Now, we can also make chondroitin sulfate from carp cartilage. So what we decided to do, Polly and I created this stun gun so we can stun the carp, and then we pay these guys to bring them out, and then we grind them up, and we are making carpillage, 1,000 milligram caplets. We're going to corner the market and make $1 million. So this is our source for chondroitin sulfate, and of course, I'm just making it up, but I like to have fun when I give these talks. So if we're going to deal with atherosclerosis, we will deal with lesions for the patient in crisis, but of course we want to focus on the circulation, the abnormalities in vascular biochemistry and cell biology that drive this disease. And of course, the central problem is oxidative stress, because oxidative stress is perceived by our body as another infection. So we're going to ramp up inflammatory stress, endothelial dysfunction, hyperglycemia, hyperlipidemia, and immune dysregulation. Aberrancy at any one foci will adversely affect the other foci. Correction at any one foci, particularly lower oxidative stress, will favorably affect the other loci and promote health. So what is our approach to atherosclerosis? We're going to assess current pathophysiology. We're going to look at carotid IMT and endothelial function. We're going to correct the endothelial function. If we do that, we're going to stabilize the IMT. If we do that, we will prevent the patient from forming new plaques and having events. Of course, we want to measure and neutralize oxidative stress, and we can quell the fires of oxidative stress with antioxidant support. The drugs that we use in conventional cardiology and some of the newer agents that we're using in cardio-rheumatology, like allopurinol and colchicine and chondroitin sulfate, all in common block oxidative stress and inflammation. And in the long run, we want to remove the acquired sources of non-physical oxidative stress that's causing Western man to become sick. Belly fat, heavy metals, organic pollutants, leaky gut, inappropriate chronic infection. These are the sources of the oxidative stress burden above and beyond what Mother Nature ever anticipated mankind would experience. So we're going to deal with oxidative stress. We're going to control lipids by blocking H-mucoreductase, because when we do that, we block NADPH oxidase, we block oxidative stress. We're going to complement H-mucoreductase inhibition, either drug or non-drug, with berberine, which activates AMP-sensitive protein kinase, down-regulating H-mucoreductase, and it improves insulin sensitivity, and it blunts transcription of PCSK9. We're going to deal with LPA. We're going to lower blood pressure with agents that improve endothelial function, such as ARBs and lipophilic ACE inhibitors. We're going to control homocysteine, and we want to really optimize the SAMe to SALI ratio, because 300 chemical reactions depend upon methylation. We need a high SAMe to SALI ratio. We'll talk about lumbrical kinase that depletes fibrinogen and promotes fibrinolysis, optimal nutritional and hormone status, phosphatidylcholine to promote reverse cholesterol transport and immune modulation, and we'll talk about berberine and pentoxaline. This completes my formal presentation, Integrative Cardiology for the Chelating Physician. Now, Charles Barkley and Kenny the Jet Smith tell us it's time to move on to the bonus coverage section, beginning with part 3.